So I really appreciate the chance to present this work today. And before I launch into the presentation, I first want to acknowledge that this was really a joint endeavor between our team at UC Davis and the team at Tidepool. Many of you are in the audience, so a shout out that we really appreciate their amazing collaboration on this work. So as everyone here is aware, we have an unprecedented level of access to our patients' glycemic data these days. It's really incredible for how many of our patients we can look at CGM data between visits. But what we really don't have yet are clinical protocols, figuring out when and how we should be looking at that data, when and how we should be reaching out to them between their visits. The other recent development that's been so exciting is that diabetes data platforms like Tidepool and others now have pop health dashboards. As you saw with some of the screenshots yesterday during the RPM panel, we can risk stratify our patients based on their CGM data, which is really exciting and opens up a lot of possibilities. So for this project in particular, we focused on our patients with type 1 who are experiencing elevated glycemic measures, thinking that they might particularly benefit from between visit contact. And another piece of context I'll add is that we've done several RPM studies at UC Davis, but in the research context, you really can't nail down the clinical workflows and some of the financial feasibility data. So this was our first effort to kind of move RPM from the research into the clinical context and really get a better sense of some of those clinical logistics that we need. So for this program, we enrolled 20 people with type 1 diabetes of at least 1 year duration and at least 3 months of CGM use. And they also had to have an A1C or a GMI at 8% or above. All the participants agreed to 4 months of clinical remote monitoring with the associated outreach from our team and associated billing. And the way we did this is that we generated weekly reports using the Tidepool Tide dashboard to identify patients who met our outreach criteria. So the criteria were anyone with a time in range of less than 30% in the prior week, or a decrease in time in range of 15% or more from the previous week, or hypoglycemia of 5% or greater, or a CGM wear time of less than 70%. So any participant who met at least one of those criteria was contacted that week, and we used a variety of different contact methods. I know there was discussion yesterday a little bit about what can be done over EHR messaging, what can't. We tried for this to start everything with text because in my prior studies and our surveys, people really prefer text outreach. So we actually had a text platform built for this. We were able to text participants directly. But we found, which I'll get to later, that there was not a high response rate over text. So we did end up using phone and EHR messaging as well in this cohort. And the contact person varied as well. So this was primarily myself and a program navigator doing this program. When it was a CGM wear time outreach, she was the primary contact, would get more information about supply issues, skincare issues, anything that was really impacting wear time. And then she would pull in members of our clinical team as needed to address those concerns. When it was a time in range or a hypoglycemia criteria, it was usually myself looking at their glycemic data and then reaching out with clinical recommendations. So this is our cohort. As you can see, they were a majority adolescent with a mean age between 13 and 14, a little over half female, half publicly insured, a mix of race and ethnicities, and they had a mean type 1 duration of 5 years, a mean baseline A1C around 9.5. And interestingly, 70% of this cohort were already using AID. And this was interesting to me because the prior studies I've done of RPM were, even just 5 years ago, the AID use was obviously much lower. And what you can achieve through weekly outreach when you're moving towards technology versus when people are already on technology, I've come to find is a very different thing. So first to go over some of the clinical metrics for the program. So people in the program received outreach a median of 6.5 times over the 16 weeks, but there was a wide range. So there were people who never met criteria for outreach, and there were people who met criteria almost every week. The most frequent reasons for outreach were actually time in range less than 30%, which was about half of our outreach events, and then CGM wear time less than 70%, which was a little over a quarter of outreach. The median time spent on outreach events was 10 minutes, but again, there was a broad range from 5 to 60. And I will say that, not surprisingly, phone outreach often took longer, although you got a lot more detail than when you were doing things asynchronously. As I mentioned, we had a quite low response rate to our text messages. So we ended up involving phone outreach 65% of the time. And 41% of our outreach events had no response from participants, even with repeated outreach in different modalities. Despite that, we actually had some notable CGM changes. So in our 20 participants over just 4 months, we did see a significant improvement in time and range from around 34 to around 40%, which was not surprisingly associated with a reduction in time spent above 180. And then we surveyed everyone at the completion of the program. So all of our respondents rated the program as either very helpful or a little helpful, which was interesting to me. It included the people who never once got outreach during the program, but they liked it. I think they thought they had a safety net there. And then 83% of respondents thought that it should continue in some form. And this was a brief survey, and there was some free text, but a lot of it was multiple choice. So we did list a bunch of potential benefits and asked them if they had experienced any of them. And the most frequently endorsed were reminding me to stay focused on diabetes between visits and making it easier to get help managing diabetes between visits, not surprisingly. And then we asked about their preferences if we were to continue RPM, how it should be done. So over half of them said they preferred weekly outreach, and then a smaller group said monthly. The vast majority, again, said we want to be contacted by text, even though they did not respond to text. And then phone was their second choice. And then when we asked about the goals of RPM, because when you think about it, you could have a variety of different targets for RPM outreach. They overwhelmingly said we want help keeping glucose in target range. And then a smaller group said we want help getting diabetes supplies. So I will preface this slide with several caveats. If anyone here has tried to get reimbursement data, you probably understand this pain, but it is very difficult to get complete and accurate reimbursement data. It's also highly delayed, so the reimbursement doesn't come in until at least 4 months after the charges are dropped. We also had a subset who were on managed care plans where there were contracted rates, and it was hard to pull out RPM fees from that. But that being said, here's the data I was able to glean from this. So for our 20 participants over 4 months, we were billing monthly, and these are the RPM codes that we use. So 99453 is the setup code that was billed at the beginning. 99454 is the monthly facility charge that's for reviewing at least 16 days of data. And then 99457 and 8 are the professional charges, where if you've had any synchronous communication and at least 20 minutes of time spent total that month, you can bill those codes. So we use these codes throughout, and for the whole program, the RPM charges totaled a little over 26,000, and the reimbursements that came back were just over 8,000. So about $100 per patient per month for this cohort and payer mix. And I say that because as I've iterated through several RPM projects, I think it really depends on your cohort, your goals, your frequency of outreach. A lot of things are going to determine what kind of charges you can drop and what reimbursement you get. The charge ranges that are shown here for public and private insurance plans are among paid claims. So there were a lot of claims that were just denied. But among those that actually were paid, these were the ranges that we got reimbursed for these different codes. And I will say the bottom bullet point is important. We were very concerned about whether participants would get copays. So we had a lot of discussion up front about if you're getting copays, we want to hear about it. We'll figure out a way to help you if it's excessive. We did some follow-up surveys actually 4 months after the program because we realized how late the charges were hitting people and plans. And we only had one participant who reported having charges passed along to them. They had a high deductible plan, and they actually were getting the full 99454 charge sent to them every month, $375. they were not very happy. And I managed to reimburse them through a faculty account kind of in a backwards way. But I think that's a concern for people with high deductible plans that we hadn't thought about up front. No other participants had any copays experienced. So in conclusion, I would say that this project showed that weekly RPM for people with type 1 is feasible using pop health dashboards that risk stratify CGM data. And it's potentially beneficial for people who are experiencing elevated glycemic measures. I think there's still a lot to work out. And I say that at the end of every RPM project. I hope in the next one I'll be able to say it's all worked out, but there are still things to figure out, right? So there's staffing limitations, there's variable responsiveness by our patients and families, and then the questions remain about variability in reimbursement. So with that, I will take any questions.
Thank you so much. The floor is open for questions. Yes, Janice. And while the microphone comes to you, I got text message saying that why pediatricians don't use Eversense because it's not approved. Come on, folks. We all do off levels and type 1 diabetes all the time, okay? I didn't say that, but I'm just saying. All right, Janice.
Thank you, staff. This is a great project, and to the Tideful team, Janice Wong from UCSF. So I have a bunch of questions, but I'll try not to ask all of them. First is clarifying, because this was a dashboard, everyone had to be using CGM at baseline, or did anyone start CGM new to participate?
No, they had to be on CGM, and I required them to have been on it at least 3 months so that they sort of had things moving.
And then you might have mentioned this, but I might have missed it. Did you do analysis of those who did not respond to the messages in terms of their outcomes compared to those who did not, or those who engaged in terms of your weekly or however frequency versus those?
Yeah, it's a good question. I'm looking into that next. I haven't done a formal analysis of it in this. I will say, based on the prior projects I've done, it's tricky because often the people who get the most touch points and we spend the most time on are the ones who are struggling the most. And so a dose response is hard to show, right? And so often it's the patients who I ended up calling them. I had patients who we lost track of, and I was hunting them down through like schools and spending all this time and talking to them, you know, for an hour with an interpreter, but they may not have had amazing outcomes. And you don't know what without a comparison group and without a randomization, you don't know whether it would have gone differently without that. And then some people who met the baseline A1C criteria, but maybe weren't struggling that much, didn't really need outreach and did fine. So it's a little tricky.
Yeah. So, and then the last one for now, and maybe we'll talk more later, but non-CGM outcomes, did you assess in this population in terms of, you know, you have all of the really great and wonderful, I think, changes in your times in range, but like their perception, maybe I missed that too, but of just participating in the program and having their frequent follow-up.
Yeah, so I mean, we did the survey. Oh, sorry, I'm going forward instead of backwards. We did survey people. There's more survey data than just this. This were just a few of the highlights, but people in general were really satisfied and wanted to continue in RPM, even the people who hadn't had much contact, which was interesting. And they perceived it as helpful for a lot of things, mainly just reminding them about diabetes. And that's what I've seen through my other sort of extra care programs too, is people say it just helps me to have another touch point, and it reminds me to keep diabetes priorities up between visits. We actually thought this would be most helpful for things like CGM supply issues and just detecting when people were off CGM, but it turned out it was more useful to them just as the extra reminders and touch points.
Yeah, because I'm wondering if some of these outcomes, and if you were to look at validated measures, if this is just as valuable, if not more valuable, than just looking at the glycemic outcomes, and if we're to do this all over time. But this is really great. I'm really excited to hear.
Well, and if anyone has thoughts on what measures to look at, because I have a research study that's going to be published soon where we actually did, with validated measures, look at diabetes distress and other things with extra touch points in RPM. And those didn't seem to budge either, even though people reported high satisfaction. So I think it's figuring out what we need to measure to really like put our finger on it, you know?
Stephanie, great project. This is Millie Vicaria from Texas Children's Hospital, Baylor College of Medicine. Quick comment that Dr. Daniel DeSalvo at Texas Children's is very well known for running the RPM program for our institution. questions for you. One, did you have any patients who are publicly insured and any hurdles getting insurance coverage for those on Medicaid? And then two, oftentimes CGM billing is done once a month, or insurance will cover it only once a month charge. So how did you sort of overcome that?
Yeah, great questions. And I'm glad you brought up Dan. I have a soft spot for him. He was my co-fellow. So we're lucky in California that our Medicaid program has an affiliated program, California Children's Services, that provides extra coverage, and it does cover these codes. So all of the public reimbursement data here is pretty much our Medicaid reimbursement data. So it's low amounts, but they do cover it. I actually was doing this project in collaboration also with Todd Alonso at Barbara Davis Center. He's doing a parallel project. Colorado Medicaid has not been covering these codes, but is about to. So it really depends on your state where they are with covering the RPM codes. These codes also can only be dropped once a month. So we didn't use the 95251 for CGM interpretation, but similarly, these are once a month codes. So we actually have a encounter in Epic that we would open on the last day of the month, total up the time spent, put in the billing codes and an attestation and show the data reviewed. And then at the end of every month, we would send that through. That's a great question.
Hi, Stephanie. Francesco Andrame from Miami. So, nice project. So, I have a question. How did you determine the number of visits for each patient? So, was this decided before starting and it was a fixed schedule, like once a week, once every 10 days? And then another question is how much time do you think it took for each patient, beside the time for reviewing and the encounter with the patient? But I mean, reaching the patient and whatever was coming together.
Yeah, thank you for that. So we looked at the cohorts data every week, and then we reached out to anyone who met these criteria. So it was a weekly cadence, but not everyone was getting outreach every week. And then in terms of time spent, I mean, thanks to the Tide dashboard, actually identifying the patients to reach out to was really quick, right? That's the beauty of these amazing pop health dashboards. It shows you who meets criteria, but the time spent actually getting in contact with them and having the conversation and helping them with what they need was super variable. So again, the median was 10 minutes, but it ranged from 5 minutes to 60 minutes, depending on the patient and what was needed and what was going on with them. And that's the other thing is I think, I know I'm probably over time, but one more comment. When you think about RPM in a new onset population, which I've done as well, and which 4T has done amazingly, a lot of it is dose adjustment, right? And you can look at stuff, you can send them dose adjustments over EHR. When I've done RPM in existing patients who are struggling with glycemic levels, there's a lot more you have to drill down and figure out. It couldn't just look at something and say, here's a message, change these doses, and they would do it. It was a lot of a conversation and getting them on the phone and figuring out what's going on and making behavioral recommendations or coming up with strategies. So it's a different beast. Yeah.
We have one question online. How often do you get a claim denied versus approved for reimbursement? And is the denial more often found for patients with public insurance?
Great question. I should have crunched that percentage number for this to tell you what percent were denied. In our population, it was not the public insurance that was denying claims because California Medicaid covers these codes. So for us, it was all private insurance plans that denied the claims, and it was just payer specific. So I don't have the number off the top of my head, but I should calculate that percentage, and I'll have it at some point. Yeah.
Hi. If we can have one last question. Carla from Rady Children's Hospital, San Diego. So predicting that this is going to be integrated in clinical care one day, hopefully, can you make any comments in the perception of the staff, the nurses that normally receive those calls? How would they take, because now you're more proactive, you're calling them. Are you decreasing the number of calls that we are receiving in our, triage calls?
The truthful answer is I don't know. I think we need to figure that out. I've struggled when I've done this in a research setting, and then even as this clinical pilot, I've struggled to figure out how to integrate it with the rest of our team. Our nurses are overwhelmed, as I'm sure everyone's are. And so I initially thought, oh, the navigator will reach out. And then when they need something, they'll pull in the nurses. And the nurses were like, that is not on my radar right now. I have so much else. You need to talk to Dr. Crossen. So it was, I don't yet know how to seamlessly pull this in. I think there's great potential for it to cut down on the extra work they're getting in their inboxes and to make it all more proactive, more individualized for what patients need and reimbursable. That's the goal, but I don't have all that figured out yet.